what are the fellowship programs across various centers in the country which are offering ROP fellowship. So I have no financial disclosures. So as we know that there is increasing number of neonatal ICUs with poor neonatal care, which is causing increase in the number of babies who are presenting with severe ROP, which is sight-threatening. Based on the study which was done in 2016, 32.4% of outborn babies who were referred for ROP had stage 5 on presentation. 89% of newborns who were referred to this tertiary care center had never got screened for ROP. And most of these patients who were referred to the center were picked up by the parents, who noted that the child was not seeing. Ophthalmologists referred only about 25%, and none of the patients were referred by a pediatrician. We are all well aware of the screening guidelines, which we follow as per the RBSK and National Neonatology Forum. So in India, we are screening babies who are less than 34 weeks of gestational age or who are less than 2 kilograms. This is to broaden the spectrum of babies who are screened, and the babies who are having risk factors, those between 34 to 36 weeks, they are screened within 25 to 30 days of life. International guidelines are different. This is how a baby who comes to us with stage 5 ROP would present with leukocoria, and that is a stage when most of us may not be able to do much for these babies. The management guidelines are based on the ET ROP group, wherein zone 1 all stages have to be treated, and babies who present with zone 2 disease, the ones with stage 2 and 3 with plus disease, they need treatment. Rest all babies need to be followed up. We have various management options which range from anti-VEGF, lasers to surgery. Now the question comes, who is going to perform these laser surgery? So there are various ROP fellowships which are being delivered at various centers across the country. Pediatric VR as a specialty is mostly a part of long-term and short-term VR fellowship. So I went ahead and proceeded at the AOS website, where I saw these are the various centers who are offering these fellowship programs. And then I shortlisted the centers who are offering pediatric VR fellowships. So I approached the designated concerned persons whose details were available on the website. I took feedback from the fellows and colleagues, and then I came up with this chart where we can see what kind of fellowship is being offered. So at RP Center AIIMS, there are two or more senior residents who are, for a short posting for up to 3 years, they perform about 100 lasers or 30 anti-VEGF injections. And the ones who are for long term, who are dedicatedly posted in the retina specialty, they perform about 300 lasers and more than 50 anti-VEGF injections. But surgeries are not being given to the senior residents. At PGI Chandigarh, it's a part of a 3-year VR training program. So these trainees, they perform about 200 lasers and anti-VEGF injections combined. Surgeries are only given in the last 6 months, and that is from about maximum of 3 surgeries, and that depends on the primary surgeon's confidence. At Arvind Eye Care Center, the specialty fellowship is the adult and surgical pediatric retina cases, and the surgical pediatric retina cases are mostly ROP. So at the Arvind Eye Care website, you can see that there's this dedicated surgical pediatric fellowship program that is for 1 year, and that is only for the fellows who have done 2 years of comprehensive VR fellowship. So, at Arvind Eye Care Center, even the clinical courses are offered for short term, that is for about 1 month, and that is basically focused on ROP and pediatric retina disorders. These are paid courses, and all of us can see it on the website. At LVPI, I contacted Dr. Subhadra, and a surgical training in ROP and pediatric retina is for 6 months. That is as a part of special course which is offered to serious applicants only. And all fellows are taught for 3 months, and more intensely to the faculty, and the ones who are outside applicants, they are trained for 6 months. They are offered lasers and anti-VEGF injections, and surgeries are only given to the applicants who are dedicated to ROP management. At Shankara Eye Foundation, there is no specific dedicated ROP fellowship program, and it's a part of comprehensive VR training. There is no surgery which is offered. At Netralayam, Kolkata, surgeries are not offered, are offered very less, at about 1 or 2, but they are mostly performing lasers and lasers. At Sushruta Eye Foundation, Kolkata, ROP screening and lasers are being done, surgeries are nil. So MGM Eye Institute at Raipur has a dedicated 3-month ROP fellowship program. So they have 30 sessions where they screen babies for ROP, and 200 babies are screened hands-on by these fellows. The ROP lasers and anti-VEGFs are only observation. 4 to 5 lasers they observe, and 15 to 20 anti-VEGF injections. At IQ Super Speciality Hospital, there is no dedicated ROP fellowship program. It's a part of the 2-year comprehensive fellowship course. Surgeries are nil, and same is the case with Center for Sight, where no surgeries are offered to these fellows, and ROP is a part of short-term medical retina and long-term VR fellowship program. So I would want to conclude that tertiary cares of centers in India have been on forefront of managing ROP associated blindness. So there's a need that these centers come together and are supported by funds so that neonatal eye health training, screening, prevention and treatment can be integrated into newborn critical care program. So ROP is a emerging and evolving challenge. There are limited numbers of centers who are dedicated to ROP screening and management. In the era of anti-VEGFs, we should there's a definite risk of non-judicious use, over treatment, and untrained should never perform these injections, because then we have seen patients coming next day with total cataracts, RDs, and we should not hurry to laser also these babies. We should be very sure at this stage whether we want to inject or laser, and early surgery is reserved for selected cases. So I still feel there is very much shortage of the fellowship programs which are being conducted for ROP, and it should be a separate program in dedicated centers. Thank you.
Thank you so much. That was really excellent. That was a great overview of what our country offers in terms of training for ROP. And I totally agree with you that given this huge population and so many centers that we have across India, there are only 9 centers which can offer some amount of ROP training. So as you know, more and more people get trained into ROP, they can next become the trainers for the next, after say whatever 3 or 5 years of experience.
Definitely.
So upscaling those centers is really essential, given the fact that more and more newborn and preterm babies are going to land up surviving with better improvement of NICU facilities. So that should be definitely one thing which we can suggest to AIOS to take up.
Definitely, yes.
Yeah, it was very nice talk, Dr. Siddharth. So next, I'll invite Dr. Manjushri Bhate. She is consultant at LV Prasad Eye Institute. She'll be speaking on ocular genetics update.
Thank you so much. And at the outset, I'd like to thank AIOS for the opportunity to deliver this talk. And this is another field which I feel is really emerging, upcoming, and needs more and more attention and more insight. That is ocular genetics. It is a subgroup of pediatric ophthalmology wherein we deal with fairly common conditions as well as some of the rare diseases. So I thought I'll just go through and capsulate a few where we've published in these rare as well as the common conditions that we deal with regards to ocular genetics. So as I said, pediatric ophthalmology deals with varied syndromic, genetic and inherited conditions, and genetic testing aids in obtaining a confirmatory diagnosis. Ocular genetics has gained foothold in advances with gene therapy, especially in conditions like inherited retinal disorders. And appropriate genetic counseling is crucial for the family, more so when they are planning further children or in case of the child that is already affected. So let's go through some of these rare cases as well. So let's begin with case 1, which is a 2-year-old female residing from Northeast India in Assam who came with bilateral corneal opacities. This was in the setting of global developmental delay, facial dysmorphism and hypotony. The parents were actually non-consanguineous, and this is the way the child presented. So she had something like a progeroid or a very loose wrinkled skin. So the face was an appearance of like an old man. She had facial dysmorphism, large skull, low set ears, and wrinkled skin with sparse hair and a pinched nose. Some of the other skeletal features showed congenital dislocation of hips, malformed teeth. She's been given a brace for the hips, and the photo on the bottom right shows the low set and posteriorly directed ears. So these were the way she presented for her ocular features, and she had bilateral central dense corneal opacities, with because of which she had the poor vision and actually came to ophthalmology first. As I've mentioned, these were some of the skeletal and the the skin findings, and most of important of which was the loose inelastic skin, for which we referred to a pediatric ophthalmologist, and she came into this clinically came into the spectrum of cutis laxa, that is loose skin. So She came with this genetic report of PYCR1 gene, which is confirmatory for cutis laxa type B, and this is an autosomal recessive condition, and it is also known as progeroid syndrome of DeBarcy. So any progeroid syndromes are those where there is premature aging of different organs of the body. And I won't go into so much detail of this, but this was one really sort of unusual case of autosomal recessive type 3 cutis laxa. She further went on to have corneal transplants for her bilateral corneal opacities, and she's got this clear corneas now, and she has got some reasonable improvement in her visual acuity. So this was one fairly rare condition that we published in Ophthalmic Genetics. This is another rare case. I'm not going into the details of this, but this patient came with multiple dermoids. As you can see, there are dermoids on the skin as well, that is on the eyelids, as well as on the cornea at the 12 o'clock, the nasal limbus. This was only affecting the left part of the left eye, and also the child had a patch of alopecia on the left scalp. There was absent hair on that side, and this was a case of scalp syndrome, which was diagnosed by the pediatrician, and for the ocular part they referred to us. Next we come to this really interesting girl. So if we look at her video and her eye motility, she's unable to abduct her eyes, and when she tries to abduct, the both eyes go into convergence. She also has this peculiar nystagmus, which sort of changes its changes its direction, as well as it seems to be more horizontal in primary, as well as a bit of like a dancing or a seesaw type in down gaze. So we can see it again in this part. And if we look at her motility, I'm trying to get her to abduct, and she's just not able to do that. Okay, so this is the on attempted abduction, both eyes converge. So this was a 9 position of gaze, and otherwise the anterior and posterior segment was essentially normal. She underwent a neuroimaging, and on her neuroimaging, it was more classical for a butterfly appearance of the medulla, which is diagnostic of horizontal gaze palsy and progressive scoliosis. She was tested for a ROBO3 gene mutation, which was positive in her case. She had not developed scoliosis at that age, and very often they tend to develop scoliosis later on in life. So this is a pre and post-op photograph just after a medial rectus recession. Next, coming to the not so rare cases, we have commonly encountered cases with ectopia lentis. In this particular, this was 2 siblings, and as you can see over here, they're tall, thin stature with long arms and legs, and this I'm talking in the setting of Marfan syndrome. But even otherwise, we see so many congenital ectopia lentis cases. In this particular family, they had the FBN1 gene, which is positive, and this is really important to get an idea of what gene, what variant is important, because accordingly the heart is involved, and we need to make appropriate referrals to the cardiologist for the same. So I'm going to rush through. This was another case of auriculo-ocular vertebral spectrum. So here you can see he has absent left ear altogether. He also has a mongoloid face. He had some amount of exotropia. In MRI, he had an absent 7th and 8th cranial nerve. And this is his fundus picture, where we can see an inferior coloboma. So some sort of overlap exists between ocular auricular vertebral spectrum and Chard syndrome. And this was published as a case report in BMJ Ophthalmology to look out the clinical criteria and to see what fulfills in each and the amount of overlap that exists in these conditions. This is another rare syndrome which we came across with, where the child had limited motility and a large exotropia in these siblings. I'm just going to rush through this case. So this was a very rare association, which was of TBX15 gene or cousin syndrome. And the child later on underwent ptosis surgery as well as strabismus surgery. So just give me 1 minute. I'm just going to go through the last one. So what is not so rare is the albinism that we see. As I said, ectopia lentis is one where we're trying to publish a large series. Vivek is also part of it. This is another one which we've published that is on albinism, and it affects all animal kingdom. And in our way, they usually present with varying amount of abnormal head posture, strabismus. Here, this child had come with this stark orange hair, and I thought it was an orange variant, but then later on came to know he's colored his hair. They have hypopigmented fundus with iris transillumination, foveal hypoplasia. We all know the features. We also looked at a study where we compared the siblings, and there's a huge amount of variations in the phenotypic presentation. So it's very important to counsel these families that if one child is affected minimally, it may not be the same case with another child. There are a number of recent advances with regards to tyrosine inhibition and degradation, which happens in these cases of albinism. And I'm just going to conclude by saying that genetic testing is a benchmark for diagnosis and management of most of these conditions, especially with advances in inherited retinal disorders like the RP65. And an interdisciplinary approach and teamwork is crucial in these cases. Thank you so much for your patient listening.
It was wonderful talk by Dr. Manjushri, and we are lucky enough, like in institution, you can just place an order for genetic testing, quite costly. So we have to, but the most important message the audience should get from here is you have to have that eye to look for the syndromes and which kind of genetic testing you'll just place an order. And in your second case, was it a scalp or it could be a exactly resembling Delman syndrome? Delman syndrome is also looks like multiple dermoid. So it was diagnosed by pediatrician. Thank you so much. It was wonderful talk.
So now I invite Dr. Patnaik Sabyasachi. Okay. So the next is Dr. Amit Raj. Achal. Okay, he's here come. So Dr. Bhavik Panchal. Anti-VEGF in ROP. Dr. Suparna is here. Okay. Can we? So Dr. Suparna, she will be talking on approach to amblyopia management.
Hi everyone, I'm Dr. Suparna from Sankar Foundation Eye Hospital, and thanks for the AOS members to give me this opportunity for to talk about the approach to amblyopia therapy. So amblyopia affects about 3% of the population, and poor vision and abnormal visual experience early in one eye in early age leads to amblyopia. The reduced visual acuity results from an amblyogenic factor influencing the postnatal neurodevelopment of the vision. There are loss of connection and distortion and disorientation of the connections with the visual cortex. Clinically, amblyopia is usually defined by 2 or more lines difference in visual acuity between both the eyes, without visible ocular or visual pathway pathology. See, unilateral amblyopia is the main. I'm talking about the unilateral amblyopia, and this is the second most common common cause of low vision in the developing and developed countries. It causes reduced contrast sensitivity, spatial disruptions, crowding, and deficits of the positional acuity. There may be a cause. What is the cause of amblyopia? We all know. I want to talk about the. So there are so many types of amblyopia. This is strabismic, anisometropic, and mixed and visual deprivation. So the prognosis depends on the age of presentation, compliance of the treatment, age of the patient at detection, cause and severity of the amblyopia, presence of complicating factors, and duration of the abnormal experience, and compliance with the treatment and the speed of tapering of the treatment. first treat the underlying cause. For this, I want to tell one baby. See, she has a -5 in one eye and -2 in the other eye. Straight away, don't tell that it is an amblyopia patient. Just treat, give glasses, and then ask the baby to adopt to the glasses. Give some adaptation time, and then ask them to come. This baby, after 1 month, she has 6/9 vision in both the eyes. So give some adaptations phase for all the amblyopia patients, so that they will get adjusted and their vision can develop in the next frequent visits. So first, don't try straight away patching therapy. Now correction of the visual ag. This is one more baby. She came with 1 meter vision with esotropia. I did squint surgery on 8th April 2019. After that, after amblyopia therapy and squint correction, her vision was 6/9 in both the eyes. So this is the baby. She got corrected and she is using, and she's happy with the treatment which I gave. So this is the way we have to counsel the babies. Means this takes a lot of time. She came in 2018 and I treated in 2019 for squint, and then after that 2023 she is following up. So don't there is no hard and fast rule for the amblyopia therapy that you stop. If the vision is improved, you should not stop. You should give a maintenance phase for at least 2 years for 2 hours a day, so that they can maintain the vision and regression is not possible. Now these are the various studies. I don't want to talk this one. And if patching the patient is not compliant, you can go for the atropine refraction. There are so many differences between atropine and patching. Atropine means the baby will not be knowing that atropine is there. So patching, if the baby is resistant to do patch, go for an atropine refraction, atropine penalization. This is the treatment of the older patient. I had a patient who came at 42 years. She has -12 in one eye and 6/6 in another eye. And nobody were treating her up to 42 years. At 42 years, we think that amblyopia cannot be treated. But I gave -12 in form of contact lens. Her vision in that eye is 6/12. So don't get... see, at 42 years, no need to treat the patient like that. You have to treat even though if they come at the older age also. See, part-time occlusion, I prefer part-time instead of full-time. Even though the first baby which I told with esotropia, with 1 meter of vision, I treated only part-time patching. Part-time patching do give good results as per as the full-time patching, but there should be regularity in patching. So for the regularity sake, I call all the patients every monthly intervals, and I will follow up to 6 months in monthly intervals. Each time I will counsel the patient, even one day you should not stop. Then that patching, even just simple counseling and frequent revisits, miracle results can happen. In that way, I am getting good results with the amblyopia therapy. In adults, now the binocular treatment came into existence. They have a shutter glasses. In these shutter glasses, for amblyopic this thing, they increase the contrast and brightness, whereas in the sound eye, they decrease the brightness and contrast. In that way, the equal input reaches the brain, and that way that treatment will be good for them. See, this part-time I wrote. Then how to sustain? So for 6 months vigorous treatment means 4 to 6 months. Whether it is mild, I will do even mild also I will do 4 hours. If it is moderate, I will go for 6 hours. But even severe also I am going for 6 hours only, not more than that. But after the regression is that slowly I taper the patching from 6 hours to 4 hours and then 2 hours. And maintenance phase for 2 years I am doing. Then if treated early, BSV can be maintained, but if it treated later, it cannot be sustained. emotional impact, especially if they patch and sit in the house, it will be very difficult for the child to tolerate. So don't encourage them to go to school and patch. Tell the parents to patch in the house itself. Make this just 2 minutes. Make them to sit in before the parents so that their emotional impact will not be done. And their studies will, functional impact means their studies will be obstructed between while they are doing the amblyopia therapy. So counsel the parents that they should monitor with the teachers so that their functional impact will not be disturbed in this period. How to maximize that I told, monthly intervals I am calling, and every time if they pamper the child, that if their vision is increased, I'll pamper by giving some chocolates or something else so that they will get motivated and then they will do patching more. So part-time patching, I told as this is the conclusion. And unilateral cataracts I do at 4 to 6 weeks of age, and bilateral 6 to 8 is the normal age. And unilateral cataract, as per my knowledge, I don't know about the other people, their amblyopia is very severe to treat. These are one more examples. This baby has this baby came at 15th day. He has a cataract in this, but I didn't do anything. I just gave atropine for that baby, and I gave the glass prescription at 15th day itself, and I started patching at that time. Now that baby, without doing any cataract surgery, his vision in the cataract eye, unilateral cataract eye, is 612. In that way, don't jump and do cataract surgeries because they have cataract eye. So, corneal opacities, if they
Dr.
have, that is poor
Suparna, it's,
resistance. Yes, yes. And ptosis is usually because of the astigmatism. Thank you. Reverse amblyopia, if you do maintenance therapy, reversal is very rare. Thank you very much.
It was wonderful talk, Dr. Suparna. The only thing we should, whenever we are just telling parents to patch, even we have studied that psychological impact on the mother of a child who is amblyopic. So that is also a most important
Yes,
factor. And have you ever tried hand-eye coordination or any other dioptric treatment for the amblyopia?
Yes, ma'am.
Any hand-eye
Actually,
coordination
in our
treatment?
hospital, low income people like
Yeah.
they'll come. So I am trying still to motivate them so that only 1 hour can be done, and then video games can be done. But
Okay.
still, nobody are responding to that treatment.
Okay.
Though I counsel
So
actually.
there are newer treatments which
Yes,
are
yes,
available for, especially for older patients.
Yes, yes,
And you rightly said adult means no treatment of amblyopia. That's a
Yes, yes, sir.
old myth. Now we
Yes,
can
yes,
treat everything.
Yes, sir.
So thank you. It was a nice talk. Thank you. Any question from audience? Okay. Thank you.
Dr. Bhavik.
And everyone. I'll be talking in brief about anti-VEGFs in ROP. In ROP in general, so I do not have any financial interest with any companies. So India has the highest number of preterm births, right? These figures are from 2010, around 35 lakhs or 3.5 million children are born with who are preterm. Okay, so this number obviously is going to increase with better infrastructure, and up to 18,000 of these infants will go blind every year if proper ROP screening is not done. This is from the government website, the data. As we know that with better infrastructure, better training, and as we move towards a developed nation, the infant mortality rate also falls, right? So as our infant mortality rate is falling down, simultaneously the rise of ROP also is occurring. Okay. In simpler words, ROP is a vasoproliferative disease which, if not treated or screened or identified, can lead to permanent blindness. This is actually a reversible blindness, or rather I'll say this is a preventable blindness. This is just few examples of how different variants of ROP or aggressive ROP can present. Okay, we have this looping shunting with avascular islands. This is a case with ocular albinism, and you have the dilated tortuous vessels. This is around halves on ROP, similarly here as well. So in the above scenarios which we saw, which were extreme cases of ROP, or rather aggressive ROP, what is the treatment modalities common to the 4 scenarios? Any options, any guesses? It's anti-VEGF therapy, okay? So just a brief about anti-VEGFs, not spending too much time. Currently, anti-VEGFs that are used for management of ROP is Avastin or bevacizumab, ranibizumab, and aflibercept. This is what people have been using. Okay, and I'll be presenting some data on the comparison of these three drugs. When you look at indications for injections, it can be aggressive ROP, any disease with plus disease, okay, any eye with plus disease. Zone 1, stage 3 also with plus can be given injection. Neovascularization of the iris, sick babies, salvage therapy after failure of laser, and subsequently before any surgical intervention, especially for a vascular condition, stage 4, stage 5 is rarely, but stage 4 ROP. The technique that we use is called as a SAFER protocol. SAFER is an acronym for short needle, use of antiseptic or antibiotic, that is betadine, prior to injection. Environmental exposure. I'm skipping the F here because extra attention detail is very important and it should have been come before. Like assess for conjunctivitis, assess for any NLDO block, like nasolacrimal duct obstruction. It's very common for children and they can have discharge as well. And follow up. Effective follow up is the key in the management of treatment of ROP post anti-VEGF. And recheck, that is a proper follow up protocol along with use of FA whenever indicated. So the next question, if we ask, what is the preferred dosage of anti-VEGF? Worldwide accepted dose is 1/2. Okay. Problem is, real world scenario, we do inject with the 1 ml syringe and with a 29 gauge needle. Some may receive 0.05, some may receive 0.04, some may receive 0.02, 0.3. We just can't measure it. So actually, AI is artificial intelligence is helping us here to understand the dosage for each child. I'm not covering that thing here, right? So lower doses are not as effective. It's already been studied. So when you compare various anti-VEGFs, bevacizumab takes the lead here. Least recurrence, increased duration of action. Earlier, maybe around 5 to 8 years ago, there were reports of neurodevelopmental delays and all, but these children are very small, so they may have as such without the injection as well. So there's no clear-cut evidence or proof for which we can say that this drug is the causative factor for the neurodevelopmental delay. Right, ranibizumab has the least amount of action, the duration, and the maximum recurrence. So this is just few examples of what I showed earlier. This is the child with ocular albinism. We have published this in BMJ case reports. Important point here is look at the choroidal vessels and look at the retinal vessels, right? This are all choroidal vessels. This is a retinal vessel. Red free will help you to identify these vessels in a better way. Similarly, this is again a zone 2 ROP, zone 2 posterior, and you can see a very good development in around 12 weeks time. In case of disease recurrence, what is the criteria for injection? Recurrence important to define. It's an anterior recurrence or a posterior recurrence, whether it is a staged recurrence, okay, or a plus disease recurrence. There's no need to hurry. At the same time, you go and inject. You can wait for 3 days, 5 days, wait for a week. Few of the recurrences can spontaneously resolve, right? You can always have an option when the recurrence happens, especially post bevacizumab. You have enough time. The retina is gone to zone 3 and all, so you can do a laser, offer a laser. Whereas with ranibizumab, the recurrence can be in zone 2 itself. You may need repeated injections. Okay, follow post anti-VEGF as per the protocol, weekly for a month, then 2 weekly. But this increases the burden for individuals, right? So what happened during COVID? We got a chance to study our patients, where we call them after a month, after 2 weeks, based on experience. We realized that patients coming after a month also nothing is going to happen. But this is only with bevacizumab, no other drug. Right, so this is what we are following in between, having a balance between weekly as well as compared to bi-weekly or once in 3 weeks, or a local follow-up as well. Short and sweet, we did a study about the efficacy of bevacizumab as monotherapy. So we were not happy with the laser performance, and that is the reason why we went ahead with bevacizumab. 298 eyes of 151 patients we included in the study. Gestational age of 31 weeks was the mean. Post-menstrual age at presentation was 36, and at the injection also was around 36. That means we did not spend too much time in delaying the injection. Meantime, for regression of ROP was around 42 weeks. So if you see, only in a week's time, the ROP had regressed post-bevacizumab. Respiratory distress syndrome was the most common systemic risk factor here. Recurrence post-bevacizumab was 16% compared to ranibizumab, it goes on to 50%. And low birth weight and extreme prematurity was in multifactor analysis were the most important factors. Along with the single dose of bevacizumab, we had 84% of children having regressed APROP. Conclusion, ROP regression rate after one intravitreal bevacizumab was 84%. Just few more slides. I know it's running out of time. Maybe the last slide. Anti-VEGF treatment is here to stay. Advantages, easy to use. Anyone can use it anywhere, in NICU, in the OPD, in the OR. Rapid response, lesser myopia, better visual fields, right? Caution, delayed vascularization, recurrence, and challenging follow-up. I have cancelled deliberately long-term effects unknown because we know now long-term effects are not that common. Thank you so much.
What was the follow-up period for these babies?
In our study, I think it was, so this was little biased in a way because we also have rehabilitation in the same campus, right? So if we, just 1 second please. No, it's okay, I don't need the time. Huh? So the mean follow-up was around 10 months, 9.19 months. But this includes the period of COVID as well in between where they could not follow up. And we have children who are operated or injected prior or may require surgery later on who are still following with a rehabilitation team. Or they may develop CVI as well. So that follow-up also was taken into consideration.
Okay, and only after one injection.
This is just the data of monotherapy.
Monotherapy.
Yes.
Only single injection.
Single injection bevacizumab. We have 84% chance of regression of ROP. We had a recurrence where 4 babies required bilateral injections for treatment of recurrence. We have excluded ranibizumab data from this. We wanted to just look at our bevacizumab monotherapy outcome. We still have a second study going on here where we are assessing the refractive errors at 4 years, 5 years, 6 years. That is what we are planning.
In one study, it was, noted that hypermetropia is more commonly seen with anti-VEGF drugs,
Yeah.
as it is seen that myopia is seen commonly with the
Correct.
lasers.
So, to be honest, it's not predictable. We can't predict which eye is going to develop. I have cases which have even -10, -12 post anti-VEGF.
Post
Right.
anti-VEGF.
Yes, few cases because genetics, environmental factors also play a role here.
That
So,
is
and
true.
plus the prematurity. The more preterm the baby, more higher chance.
Yeah, no, see, it is
Yeah.
always said that myopia is because of the laser done.
If you compare just with the laser arm,
Yeah.
definitely there is a significant amount of reduction in the myopia when the children grow up.
And what about hypermetropia?
I have to look into it. It's a good question. I'll look into
Yeah,
it.
because that is one thing I read that
Yeah. But at what
hypermetropia is more commonly-
age you are talking about?
See, it was a very short, it was not
Okay.
a long-term study,
Okay.
but yes,
Because
it was.
this eye is going to go into immetroposition process as well.
Yes, exactly. And another thing, yes, you rightly pointed out that neurodevelopment delays.
Yeah.
We are not knowing whether it is because of the prematurity of the baby, but
True.
yes, that is one thing we need
Yeah.
to take care because
So luckily Vizag has a very good infrastructure in terms of Rainbow and a lot of other OmniRQ, like very good brands have come here and even they manage 24 weekers, 25 weekers when they're in the hospital for 2 months, 3 months, 6 months as well. So then you can't just understand what is going wrong with the baby. And then after a few years we realized okay, this baby has an HIE or rather hypoxic ischemic encephalopathy or a CVI component as well.
one last question. If you want to repeat the injection,
Yeah.
so what should be the minimum time span between the two injections?
So again, as I mentioned with bevacizumab, the recurrence is later on, even around 58 to 60 weeks. By the time it is grown till zone 3. So I give an option to the child, to the parents, that let us examine the general anesthesia, get a proper IOP and a refraction check, okay, and at the same time get it laser done. That way, if I see that if at all it's progressing, it's improving, we may not go ahead with laser. But if the patient is from, so we have patients from Jamshedpur, Uttar Pradesh, Kolkata coming here, we don't give a chance. We just laser them because a small amount of
Have you
lasers are
injected,
required.
re-injected the patient?
Re-injected for ranibizumab, yes. For razumab, yes, which are injected outside. We don't inject razumab and ranibizumab, as in like biosimilar and eccentrics. We don't inject in our institute for children.
But bevacizumab, you have not
No, for this 4
Re-injected.
cases, we have re-injected. Yes.
re-injected.
Yes.
At what age? That's what I'm saying. What
Around
should be the
50
minimum gap?
Yes, 58 to 60 weeks, so 36, around 20 weeks later.
20 weeks later. Okay.
5 months to
After
6 months.
4 to 5 months.
So how frequently is
Anybody
your
from where audience?
Sorry? Yeah. No, we are examining the child at every visit. Okay, so sometimes you can make out whether there's a recurrence or not. If at 4 months also there's a recurrence, we give an option of doing laser. Sometimes the parents do not understand the condition. We take a call for the parents, depending on what is best for the child. Post injection, uh, I'm not sure. I have to look at the literature to be honest.
We have never seen.
Sorry for that.
We have never seen raised IOP.
Yeah,
following
that's what I'm
injection.
saying. I have to look at the
We
literature.
have
Never seen. It's quite
the
safe.
raised IOP after injection, but
Yeah.
transient
One-
is there clouding
Temporary
of the
it happens initially, just with the simple massage, it goes away
Yeah.
because the physiology takes care of it. But what you're asking, I'll give an anecdote for stage 4 ROP and stage 5 ROP, lens sparing and even lens involving vitrectomy with PPL. There is a chance of around 50% of those children going into ROP. So for our children who undergo surgery, we do start as a prophylactic AGM, and then we follow. When the child is big enough, then we can assess whether you need to reduce the AGM or stop it and all.
So what is your threshold of giving re-injection? Like you prefer re-injection or you want to do laser at this stage?
That's what-
Because
see,
almost
now we get a lot of referrals being a tertiary center. If there's a recurrence post ranibizumab, and if we see that it's only zone 2, I am going to re-inject. I'm not going to do laser because no point burning so much of retina when we have good evidence that it is going to improve.
so you think it improves the ROP
Definitely.
regresses?
Yes, yes.
So you don't need to do laser
No, no.
in the follow-ups.
No.
And as you mentioned, at 60 weeks you're doing FFA. It's a
No,
routine
we are not
protocol you're
doing
doing.
it. We are not doing it. We don't have it here, the FFA RedCam. A study is going on in the Bhubaneswar campus of L. Prasad Eye Institute, where Dr. Tapas is doing the study, just to understand our data profile versus the Western data profile. Profile from Dr. Paul Campbell and R.V. Paul Chen. They are the profound researchers in RO. Yes. So we are following up because they have unless they are from very far off, we ask them to go locally. But if they are from within 200, 300 kilometers, they also prefer coming to us because we follow them once in 6 months. Once the maturity happens is once in 6 months for the refraction, for strabismus. Sometimes these children can develop cataract, not because of the procedure. Okay, we had 2 cases where cataract happened because of the trauma, like because of the iatrogenic cataract. But some individuals do develop cataract. The reasons I do not know. But it is we hand over the pediatric ophthalmologist to take care of it.
How is your experience with Eylea? You mentioned.
Not used.
Acha. And not the brolucimab also. That is not.
Brolucizumab I'm never going to use with
Acha,
children.
because I just thought it was mentioned, so not
No.
used.
Yes.
Okay.
You can't risk it with the inflammation when the
course.
results are not known. No one is doing it.
Because aflibercept is recommended,
Supposedly
but
good.
I'm not sure how many
See, the
people are
cost factor
injecting.
plays a big role here. Like they're already spending so much amount in the NICUs.
Yeah.
When they come to us, they have hardly any money left. So those factors also keep up. Like I think doctor explained about empathy towards the mother. Here it's a big role about empathy towards the family as well. So those things are not covered here. You can't cover in this.
Exactly.
Yeah.
Another
Whole
thing
family.
is, I think the longest duration of action is only of Avastin.
Yes.
That's what I was asking. So
Yeah.
even Avastin is your preferred choice still, or you
Yes.
do
Avastin is
Avastin?
the
Yes,
preferred choice.
yes,
Again,
even
we
we-
see we have an advantage of an institute where we have a good micro backup and things. But outside, people, it's a risk because it's an individual choice, a doctor's preference.
But we have given Razumab and we have not seen any cases of recurrence that often.
That's very good. How much is sample size?
So it was 150.
That's really
so
good.
we
If
have
you
not
should publish
seen,
it.
yeah,
Then, that
so
is the case.
not really many patients have had, and as
Yeah.
per as myopia they were discussing. So we've said around moderate myopia, maybe around
Correct.
-3
Correct,
or
yeah.
-4. And high myopia
Yeah.
usually with lasers.
I think it's important that you can publish that Razumab data, right? If
Yes,
it-
Dr.
yes.
Mehul.
Yes.
We also use bevacizumab,
Correct.
and very rarely we need to re-inject the bevacizumab.
Exactly. Yes. So again, you are at an institute. You have an advantage of the entire team being there and all, right?
Okay.
Thank you so much.
Anybody left who, Dr. Snehal, Dr. Amit has come? Okay, so we'll, they are not well. Yeah, it's, lot of people are suffering from GI. Yeah, you also, me also. So let's have group photo and wind up the session.